Right. Thank you very much, Jessica, and welcome everyone. Good afternoon. So as Jessica mentioned, we are going to be reviewing the Medicare Analytics and Data Engine today. And so this is going to be very much an overview, and then we'll be working through some specific use cases as well. And we'd like for this to be interactive. So do please, type questions into chat or raise your hand. And then as we get to some natural breaks in the presentation, we'll be able to take those and address them. So let's jump in. And so just those housekeeping items that I think I may have just preempted myself on. So again, you can just submit those into the chat, and then we'll take those as breaks are coming up, or if there's just something that's very pertinent to what we're discussing, either in the live demonstration components or just with the content on a slide. We'll take those as they come. And so the agenda for today's presentation is that we're going to go over MAID sort of from some altitude, and then we're going to dive in. And then specifically, we're going to be talking about roster functionality, and then we'll be going over the CTI integration into MAID, including the rosters and the specific report, as well as going through some use cases that are a little bit more specific, but not necessarily limited to a single use case or a single sort of program concept. So onto the introduction. So some of the goals of MAID are that it's really designed for looking at a population health level perspective, and then it has the ability to then dive more deeply into either subpopulations and even down to the individual level. And so you can use this to monitor population level trends using, because these are claims-based reports, you can look at utilization and payment metrics. And then you can also look at the patient and population level data to improve care, monitor programs, and really there's quite a bit that can be done, and we'll go into that, and hopefully we'll be able to stir some ideas in you with this presentation. And so onto the data that underlie these reports. And so that is the claim and claim line feed Medicare claims data. And it's a rolling 36 months of claims data that is updated monthly. And so each month, the oldest month is dropped off and a new month is added. And then the latest 3 months of the 36 months are considered lagged or incomplete. And that's just due to the nature of claims processing, where some claims are submitted later than others, and others just take some time for Medicare to finalize and then include in these data. And so beneficiaries included have Part A and Part B coverage. And then on top of that, around 70% of the beneficiaries statewide also have Part D coverage. And then we are able to include prescription information for those beneficiaries. And so just keeping in mind that when you're looking at the pharmacy information in these reports, that on average, that's going to represent approximately 70% of the population, since not all beneficiaries by definition have to have Part D coverage to be included in this data set. And so now on how you have access to beneficiaries' information in MAID. And so these data allow you to get down to the PHI level. Things are often presented in the report itself in aggregate, but you are able to get down to the individual level. So this is just some information on how and whose information is made available to you. And so by default, any beneficiary that has had an inpatient or an ED touch at your hospital any time in the 36 months of the CCLF, their information will be available to you in these reports. On top of that, we have the MPA or the Medicare Performance Adjustment or MPA attribution as well. And so there we're able to flag any beneficiaries who are MPA attributed to you, to whom you have PHI access. And then for the 2 academic medical centers, they have that additional component in MPA that is a subset of inpatient. And then the PHI sharing through care coordination agreement is something that's been added to MAID in the last few years to facilitate hospitals' access to beneficiaries who don't have a touch. And that's under the auspices of the MPA, where hospitals are responsible for populations now just in their geographic areas, where they might not necessarily have had a hospital touch, but are in the community and interacting with providers associated with the hospital, such that PHI access might be warranted. And so we'll go into a bit more detail onto what that looks like operationally on the next slide. And so the Care Coordination Agreement, or CCA, is a vehicle through which hospitals can attest in what we have as the MAT, or the MPA attribution tracking tool. And so there's a small number of users at each hospital who can submit and attest to the relationship with providers and their hospital such that PHI sharing is allowed. And then from there, any beneficiary who has an E&M visit with any of those clinician partners or CTO partners, and those are providers participating in MDPCP under that hospital's CTO. Any beneficiary who has a BEDOS evaluation and management visit with one of those providers is then put into a pool, so to speak. And then from that pool, any beneficiaries who are also associated with the hospital programmatically, which is to say, if they're enrolled in a CTI, or if they are geographically attributed under MPA, or if that provider is an MDPCP participating provider in that hospital's CTO, then those beneficiaries' PHI will flow through in MAID and in the claims data that's available as well. And so I see a question that's come through from Aaron. How can we see patients who interact with hospitals in their rate-regulated space with no E&M but hospital outpatient encounters? And so for beneficiaries who don't have any E&M with any of a hospital's clinician partners and no hospital touch, be that inpatient or emergency department, if they are interacting with a facility, say a SNF, for example, or another outpatient facility, the other component that can be submitted in MAT are facility partners. And so I touched briefly on clinician partners and CTO partners. There are also facility partners. And so those can be submitted in MAT. And there, unlike the clinician partners, any claim for a beneficiary at that facility will then have that beneficiary's PHI flow through into the application. And so each hospital has some number of MAT users who can go in and upload clinician partners as well as facility partners, and then otherwise attest to their CTO partners for the purposes of PHI sharing through CCA. So I'll pause for just a moment on that, since that is a little bit heavy content-wise. Just want to see if there's any questions in addition to Aaron's.
Well, I just wanted to follow up on that. So I'm not speaking about other facilities. I'm talking about hospital outpatient facilities. So
right.
Hospital outpatient encounters, those are not included in the MAID.
Correct. And so, or rather, those are included in the data. And so because these are Medicare claims data, it's comprehensive. It's all Medicare claims for beneficiaries to which you have access. This slide is speaking to how PHI access is made accessible.
Yeah, and I guess I'm trying to get to, and I can follow up afterwards by email, but what if you have patients who are seen at the hospital in their outpatient clinics? They have no E&M codes and they have no inpatient or ED visits, but they're being seen at your hospital in the outpatient clinics.
So those would need to be submitted as facility partners separately. And so we can take that offline and follow up to see
that's useful. Thank you.
How that would happen. All right. Okay, so just some brief considerations for CTI on PHI access. And so the CTP, or sort of the CTI centric application that presents information on your hospital's CTIs, is comprehensive, which is to say it reflects all beneficiaries that are enrolled in your care transformation initiative. And so based on those CTIs, we automatically create rosters of beneficiaries, which will generally be subsets of those entire CTI populations based on PHI access. And so here, just a few examples that are not intended to be comprehensive, just examples of why there might be differences in the number of beneficiaries available in a specific CTI roster versus what you see in the CTP. And so when I talk about rosters, that's in MAID, and we'll come back to that in a bit more detail a little bit later on. And so just for example, a panel-based CTI, it might be that even if those are based on touches with NPIs in the community, and those NPIs are submitted as clinician partners, that not all of the touches would be considered or categorized as E&M, such that their PHI would flow through. And then just considering things like the current period of the CCLF would potentially remove things in a baseline period for a CTI. And so those are just a couple of examples on how or why a roster in MAID with a CTI designation that we're automatically creating might not include all the beneficiaries that are shown in CTP. And that's just for PHI access reasons. Okay. And so there's 4 different modules in MAID, and I'll go over those briefly here before jumping into our demonstration. And so generally speaking, we split these modules or the way that I'm presenting them is that there's really 3 different sort of groups of use cases. And so we have our clinical use cases, our executive use cases, and then our sort of financial and population health use cases. And so in the population module, which we will get to shortly, that starts with Population Navigator, where you're able to see a table that includes the beneficiaries to which you have PHI access. And so that's not a report as such, it's a user interface in which you can look at all of your beneficiaries, filter those beneficiaries across a number of measures, as well as create rosters and load rosters to look a little bit more in depth into those beneficiaries. And so I'm going to pause my share momentarily as I bring up my screen here. And so again, this is our demonstration site. And so none of this is actual PHI. This is all de-identified information with then dummy identifiers thrown back onto the data. And so what we're looking at here is Population Navigator. And so by default, you will see beneficiaries that are just those with an inpatient touch. And that's really just for the purposes of those potentially being the most interesting. Those are going to generally be the ones who are higher utilizing. That withstanding, if you wanted to load all of the beneficiaries to which you have access, if you select all here, or otherwise make selections in this menu, and then hit apply, this will refresh to show, in this case, all of the beneficiaries to which we have access. And I will say that these are not exclusive. So if you were to select just geographic, it would include those with inpatient and ED touches, as well as those with PHI sharing through CCA. But again, only those that are geographically attributed. And so in this view, we have many columns. And so here you can see that this is indicating that I've sorted this table by date of birth. And you can do that just by clicking the header on any column, it will sort it. You can sort it descending by clicking again. In addition, hovering over any column, we can then either filter in that column. And so here, because this is a date column, we can filter to a range of dates before or after, or onto a specific date. On some of the other columns, those are free text. And so the filter there, this is actually just an option, but say if we were in patient name, there we can search for a specific string to look for an individual. And then in addition to being able to sort in these columns and filter by them, we're also able to adjust the view. by going to this columns menu. And you can see here that we have a few dozen columns. And so the table can be a little bit overwhelming. That said, I think this is a great place to tailor the view to be those columns that are of interest. And so if we wanted to include MPA attribution so that we can load all of our beneficiaries and then sort that way, we can make that selection. We have MRN, as well as a number of other columns. And so I'm not going to spend too much time going through these one by one, but you can see that there are many, many columns. And so with that in mind, with our hospital here, where we now have 84,000 beneficiaries loaded, we're able to export this table. And I'll come back to measures in a moment. And so this Excel export button is going to be present in, I think, very nearly every report in MAID, where in this case, we'll get a table that looks exactly like we have it. But then when we get into reports where there are charts and graphs, that when you export that to Excel, you'll get the table with the figures underlying that visualization. And so what we have here is the current view and the detail view. These are two options to export our population navigator table. And so the current view exports the table just as we have it loaded here, where we have our limited number of columns that we've selected and our 84,000 beneficiaries. And so if we were to select the current view and then export that, we are prompted that we are taking protected health information and pulling that into our environment. So just to take care when doing so. But then pulling that down, our table would be, 84,164 rows with our plus our headers just for the columns that we have selected. If we take the detail view, that will be the same beneficiaries, but it will include not just the columns that we have selected, it will include measures, or will include values for all of these columns, as well as values for all of these measures. And so that becomes a very wide table, which might be of interest if you have potentially a subpopulation in which you are focused. Otherwise, I think more often than not, the current view option will get you where you need to go. And so on to these measures. And so here we have 4 different groupings, and then these can be considered like filters. And so there are 4 different families of filters. The first are the CMS's chronic condition warehouse chronic conditions. And so there we can filter to just the subset of our beneficiaries who say have CCW defined AMI, depression, diabetes, etc. We're also able to modify that filter. Instead of it showing us those who are anemic, it could show us only those who are not anemic. And then this count column on the right is the number of beneficiaries who will be shown in the view once we make that selection. So we can see that there are, of our 84,000, there are 53,000 who are not anemic, and on. Our other clinical, these are largely utilization-based. Many of these are Part D drug related. And so you can see things like proportions of days covered for various medication classes. And then we have some PQI-like utilization, and this includes inpatient and observation stays greater than 24 hours, where we can filter a population based on these utilization measures. And then we have some quality reporting conditions and medications, and these similar to the other clinical, but they are distinct, and there's more information on the precise definitions of these and everything else that we will cover today in the help section, which you can access from up here, and in the user guide as well. And so here we've got options for no, diagnosis, drugs, or both, just as an example of some of the options that we have for these particular measures. And so now I wanted to take a little bit of time to speak about rosters. So here you can see that we have, if, for example, you were interested in our beneficiaries with diabetes, now that we have everyone loaded, we apply the diabetes filter. And then if we say, wanted to look at those with diabetes, and then with a PQI related to diabetes, short-term or long-term complications, or I should say and, since these are additive filters. And so now these 36 beneficiaries are going to be those who have both a short-term complication, and a long-term complication according to the PQI definition here. And so from our 84,000 beneficiaries, we've narrowed it down to 36. And then if we wanted to load this list of 36 beneficiaries into any reports in MAID, we're able to do that by creating a roster. And so there are a few ways to create a roster, and this is one, where we've filtered our population here, and we could do the same thing by filtering on columns in concert with the measures as well. And so if we wanted to call this, say, diabetes PQI, and then if we check make public, this will allow our colleagues in our organization who also have access to MAID to be able to load this roster. So if we create roster and review, we'll get a preview where it shows that we have our 36 beneficiaries indicated here, so everything looks good. And then when we click accept, this roster is now available. And so it being public means that when you click here, you'll see that its title is in bold. This are 98 patients of interest. This roster was created in private, such that only my user, when going into the application, will be able to see it, let alone load it. And so now that we have our diabetes PQI population, we can take this and load it into any report. And so if you wanted to, say, take a look at the demographics of this particular roster, we can go here. Not going to spend too much time in this report, but just as an example of navigating through MAID, we've selected our roster already. It will pre-populate, and then the report will be loaded based on that population. And so another way that you can create rosters is by uploading a completely custom list. And so what that looks like is if we use the roster dropdown and click create, and then select upload, we're able to download a template, which looks like this. And then in order to upload the roster, you need to populate just the first 4 columns. So patient last name, first name, gender, and date of birth. And then we use those 4 columns to match the information that we have for a beneficiary. And then you're able to upload that, and it will have that information, or it will have that roster as you create it, going through the same steps as we walk through having filtered in Population Navigator. Everything from column E on are user editable fields. And so there you're able to provide information that will then persist into the application. And so what I've done is that I've created a roster here where I've input information to the date of consent and disenrollment date fields. And so I've done that because these are fields that are actually used in another report that we'll go into a little bit later on. But what we can see is that we have our first name, last name, gender, and date of birth. And then when we go to upload that information, we can see what that looks like. So here I've actually changed a few records to make sure that they don't exactly match. And so when you enter in the 4 required fields, if there's any discrepancy between what we have on the back end in terms of trying to match those beneficiaries and what is input, you'll get something like this. And so there's 2 records where there is not an exact match, and that could be because there's a suffix in one place or another. You might have a junior in your EMR if you're copying information from there, and in the CCLF, that person is indicated without junior. Or if there's a gender mismatch, a date of birth mismatch, that is what that will look like here. But when you have those errors, you're able to download a table that shows exactly who those 2 records are as they were input. And so that's this. And so we can see here that these are the information as we entered them. And then the reject reason, patient not found in database, is just because we were not able to match on all of these fields. Another thing that can happen is that I don't recall off the top of my head exactly what the phrasing is, but the other reject reason would be that you don't have PHI access to that beneficiary. So even if all the 4 fields are entered in exactly as we have them, and we're able to identify that beneficiary in the data, your hospital might not necessarily have access to their PHI, and that will be indicated here as a reject reason. Okay, so that was Population Navigator and rosters in very brief, but I wanted to pause for a moment to see if there's any questions on rosters, how you might create them based on either filtering in Population Navigator or taking a list that you have internally and then using that to create a roster. And certainly there are some more advanced ways of troubleshooting the kinds of mismatches that I was talking about, but I want to make sure that we get through as much other content as we have today, and then maybe we can circle back to that if there's time.
And I'm not seeing any hands or questions in the chat box.
All right. So back to our slides for a moment here. So again, just touching on a little bit more of what the population module has to offer is that you are able to filter your population. You're able to look at, various metrics. It's the place that I found easiest to create a roster based on the information, or rather based on the measures, or if you've got columns of interest, you're able to do that, as well as it being the place where you can upload a custom roster. But then again, rosters are available to be loaded throughout the MAID application. And so the episode module is our second module, and there it's based on 90-day episodes following discharge from your hospital. And so it's not, it doesn't represent all discharges. It's a subset that represents a large fraction, but it's for APR DRGs in, we refer to them as DRG families that are based off of BPCI Advanced. And there's also an ECIP view of MAID that is built exclusively around the Maryland specific episode program ECIP and its groupings. And so this is a place where you might look for identifying savings opportunities outside of the 4 walls of your hospital, since you're able to look at all of the post-acute care utilization in an episode for the 90 days. And then if you have programs around specific types of discharges, for example, sepsis or types of orthopedic surgery discharges, or indeed if you're involved in or participating in ECIP, this is a great way for you to get insight and detail onto what is going on within your episodes. And so we'll take a moment to look at that module. And so when you first navigate to the episode module, the first report is financial performance. And just also note that the default selection for the DRG family is AMI. And so you're able to change that selection to any that are of interest, or indeed you could look at all episodes grouped under here at once. I think one place that I think is interesting to look in terms of understanding the post-acute care utilization is the episode payment distribution. So this is showing you where, in this case, for AMI, for the period August 21 through July of 22, for the 90 days following discharge, where are the payments accruing for patients discharged for AMI from our hospital A. And so we're able to look at that. We can see that we have, one rather extreme outlier, some other people towards, sort of the shallow end of the distribution over here, as well as where most of the costs are occurring, or the most frequent costs are occurring on the lower end. And so here we can see that they're also broken out by whether there is a readmission or not. And then we can see the total episode payment for those with and without readmission to an acute care facility. Another report that I think is of particular use in the episode module is the skilled nursing facility report. And we'll get into another skilled nursing facility report towards the end of our call today. However, this one is specific to episodes. And so here, again, we're looking at AMI. We could change this to, say, be double joint replacement. And so here, we've got all of our discharges for double joint replacement of the lower extremity. And then we're looking at the skilled nursing facility use according to discharges from our hospital for the APR-DRGs in this family. And we could select an individual or subset of those APR-DRGs as well. Or indeed, look at a longer or different time horizon using any of the filters that we have available here. And so first, we have these three charts. And we've got the average length of stay broken up by the individual facilities, the average payment per episode. And so it's not, this isn't the payment to the facility. This is the average payment for the episode according to the facility. And then we have the readmission rate back to any acute care hospital within the 90 days of that episode. And then down at the bottom, as we have in many places where we have a chart, we also have a table that includes the information from those charts, as well as a little bit more, but it's not so, it doesn't allow the data to jump out visually as we do with the charts above. And then, as I mentioned earlier, that we're able to take these data and we can also export them to Excel if we wanted to look at a bit more information in detail. And so Jennifer's asking, are those discharges directly from our hospital or from any patient with a relationship to our hospital? And so in the episode module, each episode as depicted is initiated as at discharge from your hospital. And so all of the utilization shown in the episode module starts with a discharge from, in this case, hospital A. And so I have a bit more context on Jennifer's question than I think most people on the call, but that is unlike in the monitoring module, which we'll be getting to a little bit later on. And so that's, again, just how the episode module is logically constructed, is that it is based off discharges from your hospital that start any one of these episodes. And then a pair of, I think, particularly compelling reports in the episode module are opportunity summary and then the PAVE savings opportunity. And so what we're able to see here is that previously we saw that we had filters for different time horizons, as well as looking at different APR-DRGs and APR-DRG families. Here, what this is showing us is that we are sort of algorithmically identifying where there is variance in the payments following in the post-acute care setting, the first post-acute care setting, following a type of discharge. And so septicemia and disseminated infections, I think, is a relatively clinically heterogeneous grouping, perhaps more so than heart failure, though I'm not an expert. But all that to say is that we might expect that there's a lot of variance in sepsis relative to heart failure. And so if we wanted to see in more detail where there's variance in our discharges for heart failure according to the first post-acute care setting, we first make a selection here, and it will filter the three charts to the right according to only those discharges for heart failure. And so you can see that the responsible physician list has changed. And then the $10 million indicated here is the sum across any one of these charts. And so what we could also do from here is that having made a selection, and this is functionality that is, this workflow is the same throughout much of MAID, where if you make a selection in a report, you'll then hover over, you'll have we refer to this as a tooltip, and then there'll be a hyperlink in that tooltip that can take you to a sort of second level of detail underneath that number or a data point you're investigating. And so this becomes a little bit difficult to disentangle because it will look different for your hospital, because our demonstration hospital and how we construct the data, things are a little bit strange here. However, you will see clusters, which is, I think, the biggest component here, where we are clustering the physicians who we've identified as being responsible for that episode. And so for a medical discharge like heart failure, that will be the attending physician on the claim. Again, these being solely claims-based analyses. And then for any surgical discharges, it will be the operating physician on the claim, is the one who is indicated as the responsible physician in these reports. And so here we have our 5, indeed 6 different clusters of physicians according to their discharge pattern. And you'll, in fact, just have one donut chart here. But the way that we've constructed our demonstration data set, it leads to some artifacts like this. But you'll have one pie chart that shows the highest performing cluster. And I don't want to spend too much time here because it can be a bit of a rabbit hole. But it is, I think, worth taking some time, particularly if you are interested in where there is variance in the first post-acute care setting for the same APR-DRG. And so what we can see here is that across all of our discharges that we have, what we've identified as 6 different groupings according to their first post-acute care setting or their discharge pattern. And then across all of those, according to a highest performing cluster that's identified based on just this hospital, Hospital A's discharges over a longer period, that if the discharge pattern were mapped, if all discharges were according to that highest performing cluster, that this $10.5 million in savings could be realized. And so it's not necessarily, clinically appropriate that in fact, it's almost never clinically appropriate that every physician should always discharge to, for example, the cheapest or otherwise least costly first post-acute care setting. So not all those who are discharged for heart failure should be discharged to home health. Of course not. However, where there are changes or variance at the provider level, there might be opportunity there to dig more deeply to see where that variance is coming from. And so this is, in fact, PAVE. And so the drill through from opportunity summary gets us to our post-acute savings opportunity summary or our post-acute variance explorer, which is PAVE. If we go directly to PAVE, there we have up at the top, we'll have a table of all of our APR-DRGs, and then selecting any one, say for COPD, it will then populate the chart that we were just viewing below. And so there's quite a bit going on here. And again, I don't want to spend too much time here. That said, this is one of the, or I should say, these are 2 of the reports that I think are the most interesting and potentially most compelling, particularly within the episode module. And then just to jump back to the skilled nursing facility report and to show a bit more of the drill through functionality here, is that say if you're interested in a data point up here. So Aaron asks, can I repeat how a physician is assigned to an episode? Yes. And so these being based purely on the claims data, that for medical episodes, i.e. non-surgical episodes, we take the attending physician as indicated on the claim at discharge from the hospital as being the quote unquote responsible physician. And then for a surgical episode, we take the operating physician on that claim. And so we're able to do this from almost any of these reports, though this particular drill through will be a little bit different, is that we can make a selection here. We can go to post-discharge provider details, or we can make a selection in the table and then do similarly. And so here we're looking at our Long Beach post-acute care or post-acute LLC. And then we can look at specific information about this facility. And now we're getting down to that patient level or beneficiary level information that I was alluding to earlier once we drill through. And so we were just looking at across all SNFs, what their metrics are for our MGRLE discharges. And now we've gotten down to the responsible physician level, as well as below that, the individual episode level. So here again, we have the responsible physician, but then each row in this table is an individual episode as initiated by a discharge for MJRLE from hospital A. And so we've drilled through from our skilled nursing facility report to our post-acute provider details report. And then from there, if we wanted more information on this specific episode, we make a selection in this table, then we can go to episode details, and then we will have this member ID, which is their Medicare beneficiary identifier or MBI, the index admission start date, their discharge date, as well as the other columns across here. I won't read them all aloud to you. But this shows us all of the claims included in this particular episode as initiated by discharge from hospital A. And so you really can go from a very high level down to the individual level. And in this case, we can look at specific claims, get diagnosis and procedure code information as well. And then where present, we'll also have revenue center details. And so there's quite a lot here. And then as we drill through to the episode level information, there's other workflows in the episode module where you will drill through to the responsible physician information. We also have those available for you to navigate directly to. And so if we just go here quickly, and if we had a physician in mind, perhaps one that we'd identified when looking at PAVE, we could go here. We could select an individual physician. And now this will load showing us for this specific physician, their information on their discharges or their episodes for MJRLE. And then on top of that, we can show how they compare. And so in this instance, we've got one episode for this physician. That episode was discharged to the skilled nursing facility. And then we can look at how that compares to their peers within hospital A. I think there's some artifacting going on here, but this average episode payment, no, so this is accurate. So this is showing their first post-acute care setting, but for this single episode where all of the contributing payments across the different settings occurred. And then we got to post-acute provider details through that drill through that I showed you in the skilled nursing facility report. So Aaron asks, are there any plans to make these views available for CTI episodes? So unfortunately, no, I'm not aware of any plans to do that specifically. However, as I mentioned, we do have these CTI rosters that are created. They will be a little more intelligible than sort of these very generic names that we have in the reports here. And so if you were to maybe take this back to financial performance and then load a trigger-based roster. And it seems that none of the beneficiaries on a trigger-based roster have any episodes, unfortunately. We can try a different one. And so here we do see that there are beneficiaries on this CTI roster who do have episodes. And so there is, information that you can get that way. It's just important to remember So I'll take this back to default for a moment, that the episode module does not account for every discharge from your hospital because it's just the subset. It's a large number of APR DRGs, and so a very large portion of discharges, but it is not comprehensive. And so you can see that list here. It's also included in the user guide if you're able to, or if you wanted to look for a bit more information on exactly what is included here. So Aaron asks, do you have an estimate of what proportion of discharges are covered by the episode view? I do not, unfortunately. So I'm pausing my share for a moment. We'll jump back to the slides for a second here. And so there is quite a bit that you can do in the episode module, so long as you sort of go into it with a bit of a plan, as I think is probably a good idea to do with the entirety of MAID, is that it can be a little bit overwhelming, and hopefully I'm helping to orient you at least a little bit, but then going into the tool with some specific questions that you'd like to ask, and then finding ways to answer those by looking in specific places and or by limiting the population you are showing in the reports to being those of interest. So onto the pharmacy module. And so there's a few different ways to use these reports. And so we can see we've got our financial use case on the left where we can look at, just the tracking prescription drug use over time, as well as, looking at the breakdown of generic versus brand prescriptions that are being used by your beneficiaries. And then I think perhaps one of the most potentially actionable pieces, though it does take coordination in many cases with providers in the community, is looking at the medication synchronization opportunity reports. And so we'll take a look at those now as well. And so do please keep the questions coming. It's great to see the amount of engagement that we're having today. And so on to the pharmacy module. And so as we have in each of these modules, when you first click in, it will just load the first report. This one is the top 200 drugs. And what this shows is by the claim count, it orders the top 200 drugs for our beneficiaries with Part D coverage. And so you can see here that unlike in other places here, we have a single time period that's available. And so we're showing a reporting period from November 21 through October of 22. The data that you have here in production will be a little bit more recent. And just a brief aside, a way to see what data are available for which period, if you hover over this eye icon up at the top right, this will show you the period of the CCLF that are shown. So our 36-month period for our demonstration site is from December 2019 through November of 2022. And then keeping in mind that the latest 3 months, and so that would be, I guess, October, November, so September, October, November of 2022 are those lagged months where those are generally not included in the default views of many of these reports. Anyhow, back to pharmacy. So here we have our top 200 drugs. And then if we wanted to dive even more deeply, we can then get to patient level information. We can see who those beneficiaries are and indeed who the prescribers are, in this case for this particular statin. And so I've just made a selection in the table, and then hovering over that selection, I saw the tooltip with the hyperlink to the drill through. So here we now have our top 200 drugs detail report looking at atorvastatin. And so we have our prescriber name, the pharmacy name, and then the beneficiaries who are filling for that script. at the various pharmacies under the prescriber. If there are prescribers in which we have particular interest, we can select any one of those using this filter. We can find individual beneficiaries using our member name dropdown. There's a free text search up above. Otherwise, we can scroll through and make an individual selection. And then we can also filter this according to a specific pharmacy. And so I was speaking about the medication synchronization opportunity summary report. And this, like others, includes a number of drill throughs. And just like we did for the top 200 drugs, we were able to drill through once. In this case, we can drill through as well. And so here, the data are aggregated at the pharmacy level. And what the synchronization opportunity is quantifying is the number, or rather the percentage of beneficiaries who are filling multiple prescriptions on multiple days in a given 30-day period, which is to say that there's the opportunity for that beneficiary to have their prescriptions revised such that instead of filling on multiple days, if they can fill those on a single day, that is one less barrier to medication adherence. And so you'll often see that the percentage of out-of-sync patients is, well over 50, and that's been the norm from what I've observed over my time looking at these reports. And so there is opportunity there, though the logistics of realizing that opportunity can be a little bit daunting. But starting with our Walgreen company pharmacy here, we make a selection in the table, and then we can drill through to the opportunity detail view. And so before, where we were looking aggregated at the pharmacy, we were now all within a single pharmacy, but then looking at the beneficiaries as well as the information specific to them. By default, it will show us those that are not synchronized. We could change this to be those that are, or we could show them all beneficiaries. We'll leave this as no, or maybe I just changed that to all accidentally. But what this shows us is, so now we are seeing all of them. So a beneficiary who is synchronized, as an example, this individual they're using one pharmacy to fill one prescription from one prescriber. And so if you have one prescription, it's just about impossible not to be synchronized. But a beneficiary who is filling multiple prescriptions. So this individual, for example, is using 2 pharmacies for 4 different prescriptions from 2 different prescribers, and that they're filling those prescriptions on average about 3 days apart. And so we don't have, any ability to drill further through from here. However, you can identify, say, by hovering over these column headers, and you're able to do this in many reports, though I just caution you that sometimes it won't behave as intuitively as you might expect. They're able to sort this table. And so here you can see that we've got a number of beneficiaries with more than 15 prescriptions, filling them at numerous pharmacies. And so, for example, here we have a beneficiary who's filling on average 3 prescriptions per pharmacy or per prescriber using a single pharmacy. So this is, I think, one report that gives you some information on, I mean, there's not much more to it than that there is a lot of medication synchronization or asynchrony out there. And this is one view on it. And so I'm not going to spend too much more time here in the pharmacy reports, since this doesn't represent your entire population. That withstanding, there is quite a bit here, and I'd encourage you to poke around there, particularly if you work with your pharmacy team or if you are indeed a pharmacist, that there might be something that's of value there. All right, so onto the monitoring module. And so this, a little bit like the population analytics module, is a little bit of a higher level view. again, with the ability to drill through. And so there's several use cases here. And again, any of the use cases that are on these slides are not in by any means comprehensive of everything or every reason why somebody might be going into these reports. But generally speaking, the monitoring module is a way to look at where population level trends exist. And there's a few different ways that the data are presented there, and we'll go into those in just a moment. So there's the first report when you get into there, which I'll in fact why talk about it when I have every intention of showing it to you. It shows a slew of metrics all at once for your population. And so that is the key utilization metrics report. And so this one does take a moment to load, and that is only because there is quite a bit that's going on in this report. And so once this loads, we'll see that there are reports for our per member per month over time. Again, looking at our default population, which is to say anyone and everyone, having made this selection in our attribution type menu, as well as things like readmissions, primary care utilization, and a number of other metrics. So this one, as I said, does take a moment to load, but I think it's well worth the wait. And then this will give us some grounding once we get into some of the other reports that are available in the monitoring module as well. I think we're now bordering on this being sort of the curse of screen sharing, where it's taking longer than usual, even for a report that takes a little while to load. So I do beg your pardon. And so perhaps if you have any questions that you've been sitting on for a while, now would be a good time. So Aaron asks, what tools do you recommend in MAID to explore length of stay variation and opportunities for improvement? So that's what an excellent segue into the report loading. So here, this isn't going to show us, this will show us variations in length of stay over time, not necessarily clinically. But what we could do is that if we had a specific population in mind and we had created a roster, that we could then look at the changes in inpatient length of stay for that population in this particular report. So here we can see that we have our total payments, our per member per month. And again, these are not just limited to our hospital. This is all utilization. And so because we are looking at our Medicare beneficiaries, that we are able to see all utilization for these individuals. And so I think a particularly interesting metric in this view is the percentage of all readmissions that go to a different provider. And so these are all-cause readmissions that are having been discharged from your hospital are being readmitted to a different acute care hospital. And so there's something interesting there. And in several of these specific charts, you're also able to drill through. And so if we wanted to see, for example, the specific hospitalizations that occurred in August 21st that are showing on this data point, we make a selection here, and then we can drill through to admission details, and we'll be able to see specific information on what's going on there. Similarly, for our ED visits, Our length of stay does not have that drill through, but just as we were able to do elsewhere, that making a selection in many, if not most of these charts, we're able to drill through to get more specific information underlying that data point. And then one thing that I think does get overlooked sometimes is that you're able to click and drag to select across multiple points. And then once we drill through from here, it will show us all the information for that period. And so one reason that I wanted to start with this key utilization metrics report is that this was the template that was used to create the 2 key performance metrics reports. And so we'll start with the index enrollment. And you can see here that whenever you navigate to this report, it prompts you to select a roster in order to view this report. And that, of course, is by design. And so I've taken the liberty of creating a roster earlier today that demonstrates the functionality of this report. And so you may recall that, no, not here, in our roster upload template, that we have the date of consent and disenrollment date fields that are optional when loading the roster. However, this report uses these fields as delineation points in the report itself. And so something appears to have gone a little awry here. So we'll see if the population health behaves a little bit more nicely. But what these reports do is that it will show us what's going on with, say, if we had a program and the beneficiaries who are participating in that program with their different enrollment dates and disenrollment dates, that we can use that information when creating a roster and then loading that into this report. It will show us utilization with respect to those points. The difference between the index enrollment and population health views of this report is that in the population health view, it shows us all utilization over time for the beneficiaries in our roster and indeed this program. So if we knew that this program, say, started on January 20th, that will shift this vertical line just as an indicator of when the program started, and then as patients are enrolling in and out of it, what their utilization looks like. I'm not sure why it didn't load as expected with the indexed enrollment, but the indexed enrollment view of the same report, where all of the charts are the same, instead of showing calendar months, it stacks all of the beneficiaries' date of consent, as the field is called. So it takes all of these dates of consent, it puts all of these at month 0, and then shows utilization relative to that. And so instead of being January 20, this would be month 0, +1, +2, +3, -1, -2, -3, etc. The roster churn shows us when beneficiaries are being added, when beneficiaries are dying or being disenrolled. And so it's another way to look at not just program performance, but with the roster churn chart, we're able to see beneficiaries coming into and exiting a particular program or intervention. Okay, so I'd be remiss if I didn't cover one of my favorite reports in MAID, and that is the pair of SNF utilization reports. And so we have an unmasked version, which will allow us to get to PHI level, and a masked version, which does not show any PHI and in fact suppresses any cell sizes less than 11. And so this is as it would be shown in your view. It'll have this indicator. Again, a reminder that nothing that we're looking at today is actually PHI. So what we have here is that now we are looking at all beneficiaries to which we have access that have had any SNF utilization. And so a big difference between what we're looking at in this report in our demonstration site and what you have available in production is that in addition to this SNF provider dropdown, you also have a discharging hospital filter. And so the reason why that's important is that it could be, and indeed is, any hospital that has discharged any of your beneficiaries. And so any of these beneficiaries that has any SNF utilization is what we are capturing here. And so if you were to take, if we had the discharging hospital filter in our demonstration website, that if you filtered that to be hospital A, you'd be only looking then at the utilization, the SNF utilization following discharge from your hospital. Here, however, we're looking at all SNF utilization for any beneficiaries that we have access to. And so what's, I think, particularly useful in this report is that unlike the SNF report that we were looking at earlier in the episode module, this is looking at all discharges, and we can filter to subsets of those. And so if we wanted to look at, say, discharges for stroke, we make that selection, the report will refresh, and then we will see of our 8,200 total discharges, what that subset is for stroke. And now the numbers drop rather precipitously, but then our risk adjustments, which I've not discussed yet, those are then recalculated based on only those that are discharged for stroke to a SNF. And so the risk adjustments here are done to allow you to compare facility to facility with a more apples to apples data presentation, where we take a little bit of the wind out of their sails when a SNF says to you, but we're special. We get the sickest patients. Our patients are much more medically complex than the one down the road that appears to be doing much better on their metrics. And so we are risk adjusting the average SNF payment and the average length of stay based on the PDPM rate, which is just a modifier that's used in the Medicare payment methodology for SNFs. And then the risk adjusted readmission rate, we are using an AHRQ measure for, it's called the planned all-cause readmission rate. And there we are able to calculate an expected readmission rate according to discharge disposition and clinical characteristics and demographic characteristics of the individual beneficiaries, and then compare that to the observed readmission rate to calculate a risk-adjusted readmission rate. And so here we've got a question. Could we get the counts of beneficiaries discharged to a SNF who are readmitted within 30 days to a hospital during the SNF stay from this report? Indeed, yes. So, I mean, you would have to, I think, work backwards into that to get that exact count. But the readmission rate is the observed readmission rate. And so these are 30-day readmissions following discharge from the hospital. So if a beneficiary is discharged from a hospital on January 1st, admitted to a SNF on January 2nd, and readmitted to any acute care hospital on January, I guess, 30th, that would be the last day that they were eligible for their 30-day readmission, because the 30-day clock starts at discharge from the hospital. And so if we wanted to look at the readmission rate for a specific SNF, we're able to do that here by having drilled through, and I'll show there's two different views that you have available to you, or two different drill throughs that you have available in this report. The first is this beneficiary details, indeed by a specific provider. And so what this will show is that we could export this to Excel, but of the beneficiaries in this table, there's one that has a readmission since the APR-DRG for a readmission is populated. And so, Irene, I hope that helps to address your question. Unfortunately, it does require, to get the actual counts, it does require sort of drilling through to that individual facility level. But this does get you there. And again, you can export this table to Excel. Okay, and then Jennifer asks, can you talk a bit about the power of the risk adjustment depending on the denominator of patients discharged to the SNF? I thought this had some impact, and indeed it does. And so one reason why the reports did not or were not initially published with a discharging hospital filter is that for the purposes of risk adjustment, we were trying to keep the volumes as high as possible. And so I'll show you why that is the case in just a moment. So here, again, we've got our very big numbers where you might see some discrepancy between the actual readmission rate and the risk-adjusted readmission rate. But all of these numbers seem, below the clouds, so to speak. But if we were to change this back to stroke, so we just had it, where we had some pretty small numbers, what can happen is when the volume is so low that we end up with some strangeness where we can have risk-adjusted readmission rates that are above 100%. Here we've got 170%, and that's just because if we have in this case, this would be a single beneficiary who was readmitted, and that's the 100% here. But the risk-adjusted readmission rate is such that when we are doing the risk-adjusted calculations, that it comes out to be something that's actually nonsensical. And so always keeping in mind that the risk adjustment is most powerful when there is real volume there to use to compare. And so I hope that's what Jennifer was getting at when talking about the denominators in the risk adjustment. But something to consider is that because risk adjustment is essentially, in this context, a population level metric that's being used to compare across, in this case, all of the 224 discharges, that looking at handfuls, even 5 discharges, that this number might not be something that you'd want to try to extract too much meaning out of. But so if we were to look at a different DRG family, say AMI, where we might have larger volume, that there might be a story that's easier to tell, or at least one that's more interpretable. So again, we've got very low volumes here. Not sure where all of our discharges are in our demonstration site, but all that to say that when looking at this report, as powerful as it is, that you don't see a facility with 5 discharges that has a readmission rate of 1,000, or a risk-adjusted readmission rate of 1,000%, and you think that must be, they must be doing something terribly wrong. It's just an artifact of the actual risk adjustment. But here you can see, among those with, some number that isn't absolutely minuscule, that the risk adjustment is something that's telling a little bit of a story. And so we did see that we were able to drill through to the beneficiary details. The other drill through here is the SNF utilization trend. And here we'll get to a few metrics. And so here we're looking at sepsis. And this will show us the trends over time for this Brook Grove facility, as well as relative to all the facilities that we had in that previous view. So again, the risk adjusted metrics are always done according to what is shown in the report. So the risk adjustments are for all sepsis discharges from, all sepsis discharges from any hospital to beneficiaries that we have PHI access to for this time period. And so there's just a little bit here that can sort of just, if you found a facility that was of interest, this can help you understand whether there was something bizarre in a given month that was throwing off their overall rate, or to see if, for example, their length of stay is relatively constant, though in this case, we've got 1 month where they dropped much, much lower than they had sort of been trending towards otherwise, with the exception of the first month. And so This is a report that really does allow you to understand what's going on within your SNF network, and to say, using the discharging hospital filter and then keeping in mind the limitations and constraints where you want to make sure that you are looking at those with volume when trying to put into context the risk-adjusted metrics, that you can really understand what's going on within your SNF network in aggregate, as well as within specific DRG families or within service lines. And so we'll take this back to all hospital discharges, and I'll show you one more bit of functionality before trying to breeze through some more of the slides. And so we have this little icon up at the top right here, where if you change this from its default minus to a plus, it will then create subsections under each SNF for all service lines. So here we have a multi-select. And so we could select, say, cardiology and neurology and orthopedics. And I won't do that now, but it would refresh to limit to this view to show those 3 service lines, as well as the SNF subtotal. And so the subtotal, the risk adjustment, then would be done across the 8,200, across all SNF admissions or discharges. Excuse me. But then within each service line, the risk adjustment is then only among those. So for example, the general medicine, we don't see the total here, but the risk adjustment for the general medicine is only done with respect to those general medicine discharges as admitted to SNFs. And so that's, I think, an important piece to understand in viewing this report, that when you are looking at the service lines, or indeed the APR-DRG families, whatever you've selected and however you are viewing the data, that the risk adjustment is done in kind and in a logical way, so that only when things are all grouped together, that you're looking at, you're looking at, or rather the risk adjustment could be incorporating significant differences in, if a particular facility only admits patients discharged for services in the neurology service line, and another does only orthopedics, that we might expect very different measures and very different sort of risk adjustments to be done based on clinical differences within those 2 populations. But then when you were to break those out, you would see that those are different, and indeed the risk adjustment for those 2 hypothetical facilities, when broken out at the service line level, wouldn't interact at all. Okay, so that was MAID and some of its highlights in, I think, very brief, despite the time that it's taken me to discuss all of these. I'll say briefly that this DEX button and the administration button will not be available to most users. The DEX button is for downloads of the actual claims data, and those can be very large data sets. There is more than likely 1 or 2 users at your hospital or in your hospital system who have access to those. But those are for taking data and doing analysis outside of these reports. Okay. So the session, as Jessica said, is being recorded. One idea is that we are going to try to break up some of this recording into some thematic chunks that can then be accessed in a little bit more digestible manner through the CRISP Learning System website, including things like where I was discussing how to build rosters and then going through the different modules as well. One thing that I just wanted to make sure to touch on is that we do have the Care Transformation Initiatives report, and this is in the population module. And so you can see on the left, when you click there, you load into Population Navigator, but then down at the very bottom is this Care Transformation Initiatives report. And there you can select your CTI roster or just leave it to default, and then select individual thematic areas or specific CTIs. You can also select the assessment period and the performance time period to limit what is being shown there. But if you were interested in, say, the trigger date for episodes at the beneficiary level in a specific CTI. You would load that roster, and then you could export. I've cropped the screenshot here, but you could then export that table as loaded into this report, and you would have all of the trigger start dates for beneficiaries in that CTI and on that roster. And then one last bit on rosters is that when you do load a roster, you might see that the little eye icon is red. And that is just a visual indicator that the attribution types that you have selected have limited the number of beneficiaries that are loaded. And so whereas I was navigating through the demonstration site with all attribution types selected, I would not ever see this eye as red. If I were to go in and forget, for example, that the default selection is only inpatient touch attributed, I could end up in a situation where I load my CTI roster and then I'm not showing all of my beneficiaries. And so if you hover over that, that's how you get this little table here. It will show you the total number of unique beneficiaries is 76. And if I were to, say, export the table, in this case from the Care Transformation Initiatives report, I wouldn't see 76 beneficiaries. This is showing me that. However, I've loaded this, that I'm missing some number of them. Okay, so there's a little bit more here, but I did want to take the last few minutes just to see if there are any more questions, or if there's if there's anywhere in particular that anyone would like us to spend the last few minutes going back over.
I'm not seeing any questions, Dan, but I just did drop the link in the chat for the learning system page where this recording or even some snippets of this recording will be posted.
And of course, I'm happy to make these slides available as well. Well, all right. If there aren't any more questions, I'd love to thank everyone for your time and attention this afternoon. And look forward for more communication from Jessica, the CRISP Learning System team, and I on potential future sessions such as this and beyond. So thanks again, and have a good afternoon, everyone.
And a big thank you to you, Dan. We really appreciate it.
Thanks, Jessica. Okay, take care, everyone. Bye-bye.